Great. So because we're recording this webinar, it will be available on our YouTube page. The North Carolina AIDS Action Network will also have it available and post that as well. We'll also be sharing some of these slides as well as some additional tools from some of our speakers. We remind you all to please mute your phones if you're in a particularly noisy space. You can also use the chat function for questions or raise your hand virtually. And there's options for that. And, well, welcome. And so I will start off by turning it over to Adam Linker, who's the Program Officer at the KB Reynolds Charitable Foundation Trust.
Yeah.
Welcome, Adam.
Thank you, Judy. Like Judy said, we are co-hosting this with the Latino Commission on AIDS and the North Carolina AIDS Action Network. So as the slide says, I'm a board member of the AIDS Action Network, where our mission is to improve the lives of people living with HIV in affected communities through public policy advocacy, outreach and education with webinars like this and a lot of other on-the-ground outreach activities, and community building to reduce stigma and increase the visibility of people living with HIV. Prior to coming to the trust, I worked a lot with the North Carolina Justice Center in implementing the Affordable Care Act. So our fearless leader at NCAN, Lee Storrow, had asked me to moderate this because I've worked on these issues a lot in the past. We feel like it's particularly important this year to get education out there and word of mouth and really spread the word about open enrollment, because it is it's a year where we know that there have been sort of attempts to undermine the law, even though we know that the Affordable Care Act after the most recent election will most certainly remain the law. We know that there are still very much affordable options for people and even new options for people to enroll in coverage. But there's also new policy, administrative policies in place that we need to pay attention to. There are different plans available every year, so people really need to find in-person assistance, which you'll be hearing from folks who provide in-person assistance later in the call, to find the plans that best fit people. And we know the advertising budgets for the Affordable Care Act have been cut, and also some of the federal support for that in-person assistance was also reduced this year. So at the KB Reynolds Charitable Trust, where I work, we have tried to supplement some of the lost funding for in-person assistance and for communications, and tried to make up for some of those federal cuts. But we are going to have to ramp up our efforts in many ways because we can't make up the difference at the foundation level. And so we're really going to have to rely on more word of mouth outreach and education. And that's especially true with folks who are harder to reach populations, and many of the people and the places we all collectively have a mission to serve have a harder time reaching folks with information and education and making sure that folks are getting the right plans for them. So with that, I want to go into some of our presenters today. Our first presenter is Mark Van Arnam, and he's co-director of the North Carolina Navigator Consortium. So this is the consortium that really manages for several years some of the largest federal grants in the country for in-person assistance. They've had some cuts this year, but they still have a very robust program in the state. And so he can talk some about the in-person assistance and what's going on with some of the plans that are available this year. Prior to coming to the consortium, he was the Deputy State Director for Enroll America in North Carolina. And Amanda Greene is the HIV Medication Assistance Program Coordinator for the North Carolina Division of Public Health. That is the program formerly known as ADAP, or the AIDS Drug Assistance Program. Prior to coming, so she'll talk some about that and premium assistance available. And prior to coming to North Carolina, she worked for the Philadelphia Department of Health in the AIDS Activities Coordinating Office. So We are honored to have both of them, and I think they'll provide us a lot of great information. And with that, I'll turn it over to Mark, who will be talking about the Navigator Consortium.
Great. Thank you so much, Adam. I really appreciate it, and appreciate Lee and Judith and everyone for giving us the opportunity to come and spend a few minutes talking with you all this morning about this really important issue, both to this community and to different communities all over the state and all over the country. So I'm really excited to be able to have a few minutes to talk to you about some really key important things that folks across the state need to know as we are deep into the open enrollment period. Next slide, please. So just to give you a quick update on what the North Carolina Navigator Consortium is, we're a network of 7 nonprofit organizations led by Legal Aid of North Carolina that cover all 100 counties in North Carolina. So no matter where we're going, if from Murphy to Mangio, from the mountains to the coast, we have in-person assisters that are there that are able to help consumers understand their options under the Affordable Care Act, help consumers to complete the application process, help consumers with education and post-enrollment support, all those sorts of things. We are a year-round program, again, in all 100 counties of North Carolina. Last year, I think that this is a good number to highlight. 519,803 North Carolinians selected health insurance plans through the marketplace during the last open enrollment period, and 9 out of 10 of those that selected a plan were eligible for financial assistance. So they got some sort of financial assistance to help pay for their coverage and to make it affordable and make it something that they could live with and really take advantage of. Next slide, please. So here's just some pictures of some North Carolinians getting covered. These are everyday folks that live and work in communities just like ours that have gone out, gone to enrollment events or made an appointment to see one of our assisters to complete their application and get covered, often for the very first time or for the very first time in a long time, or to stay covered. So we've got a lot of folks that are coming back and re-enrolling and making sure that they're updating their information in the marketplace because, like Adam said in the beginning of the call, new plans and new prices are available. So even though somebody comes in and gets enrolled once, they can do what's called an auto re-enrollment. But we recommend that folks come back in and sit down with the in-person assister and let us know if you've had any life changes, any changes in your income, any changes in your medical needs. And oftentimes you can find a plan that's better suited for your needs and your budget by coming in and updating your information during each open enrollment period or with any life change that you might have. Next slide, please. So we wear a lot of hats at the Navigator Consortium. We do not, a lot of folks think about this as a short kind of 6-week open enrollment period where folks are able to get enrolled and then it's done until next November. But that's certainly not the case. One of the main things that we do, of course, is get folks covered by helping them complete their application and understanding the application process and making sure that they get everything that they're eligible for in the way of tax credits and different benefits. But we also help people understand health insurance. A lot of folks haven't had health insurance in a very long time, or some folks have never had it before. So we help folks understand what things like co-pays are, co-insurance, how to make a doctor's appointment. Very simple things like that are really quite important to the community that we're working with, and we do that every day. We also think it's really important to connect the community with resources. We all know that in North Carolina, we have not yet expanded Medicaid, and hopefully that will happen someday. But right now, folks that are under 100% of the federal poverty level or above 400% aren't eligible for advanced premium tax credit, so oftentimes this coverage is unaffordable for them. So we want to connect those folks with community resources to make sure that they have somewhere that they can go and get some sort of care and get help and get the support that they need. We also work on appeals for incorrect eligibility determinations. So if you feel that you're getting an incorrect eligibility notice, or we are noticing that as we're completing your application, we'll take that up through the next levels and represent you as we go through the appeals process. So we make sure, again, that every consumer that we're sitting with has the opportunity to get every sort of benefit and the tax credits and everything that they are eligible for. We also help consumers respond to marketplace requests. Oftentimes you'll get requests for additional identity verifications or income verifications, and we're there year-round to help the consumer respond to those requests and get those requests up to the marketplace in a timely fashion, so there is no lapse in coverage. We're there to help with billing and payment issues, as well as reconciliation during the tax season. There are tax implications, especially before when we were talking about the mandate. There was a lot of tax implications in that, but there are also tax implications when you're talking about receiving tax credits to help pay for your coverage. We're there to help you and also tax professionals. We're at places like VITA sites and AARP sites to help tax professionals understand the reconciliation issues that they need to handle as you file your taxes at the beginning of each new year. And again, we are there to help address complex issues. There are a lot of folks that come in to our doors that have very complex medical issues, or lots of folks in their family with different medical issues, and all sorts of different sort of issues that come in front of us. We are there to help folks address those issues and pick plans that are best suited for them, their needs, their budgets, and the issues that they may have. Okay, next slide, please. So just real quickly, I want to give just a basic eligibility overview of who is eligible to get coverage in the marketplace. So the marketplace, you'll hear me refer back to, that's simply the place that you go and shop for coverage through the Affordable Care Act. So healthcare.gov, that's the marketplace. You can get on there and see all the options that you have available with the different providers that are in your area and the different plans that are in your area. So to be eligible for marketplace coverage, you have to have no other coverage available, such as Medicaid, Medicare, or employer-sponsored coverage that meet what's called minimum essential coverage. So I've had a lot of questions recently, for example, family planning Medicaid or Medicaid for women that are pregnant. That does not count as minimum essential coverage. So those folks would still be eligible to take advantage of marketplace coverage. So it's only insurance that meets that minimum essential coverage standard. You must be a U.S. citizen or lawfully present immigrant. You must have a household income of between 100 and 400% of the federal poverty level to receive those advanced premium tax credits. Now, you can pick a marketplace plan if you're below 100 or above 400, but it becomes very unaffordable at that point because you don't get those tax credits to help pay down your premium and those premium costs on a monthly basis. So for a household of one, 100% of federal poverty level, according to this year's FPL guidelines, is $12,140. And 400% of that federal poverty level would be $48,560. So if you are a household of one and fell anywhere in that range, you would be eligible for advanced premium tax credits that you could apply towards your monthly premium. Those tax credits are paid directly from the federal government to your insurer, so you don't even have to worry about reconciling that at any point either. A family of four, 100% of FPL is $25,100, and 400% of FPL is $100,400. $400 a year. So just a quick example here to help you guys see how this works. So there's a 35-year-old single male, a non-tobacco user. He lives in Raleigh with an annual income of $20,000. Due to his income, he can get a bronze plan of $0 per month. You have plans in different metal levels, so bronze, silver, and gold. Bronze will, of course, be the cheapest plans, but they'll have a higher deductible. So if he went to just $64 a month, this single male that we're talking about with his income, if he paid just $64 a month, he could get a silver plan with a $700 deductible and a $2,500 out-of-pocket maximum. So we will present all of those options to a consumer as they come in and help them pick the plan that's right for them. Some folks want just that low monthly premium or $0 monthly premium, but we help you to understand that you have to then deal with the higher deductibles and make sure that that's something that would work out with you with any kind of medical issues that you have or any other issues that you might have. Next slide, please. So these are some key facts that I think are very important for everyone to remember between now and from here on. As long as we're talking about open enrollment, these facts are really important. So first of all, you have to sign up by December 15th. I think probably there's several people on this call who remember you used to be able to enroll all the way into January. That is no longer. The open enrollment period has been cut in half, so you must take action by December 15th. No matter if this is your first time getting covered or you're re-enrolling, if you want to shop and make sure that you're selecting a new plan or checking out the new plans and prices, you have to take action by December 15th. Again, coverage is cheaper than most folks think. 9 in 10 North Carolinians who enrolled last year got some sort of financial assistance to help pay for their premiums. Most people were paying somewhere between $50 and $100 a month, so oftentimes less than your cell phone bill or your cable bill. And also, premium prices are going down in some areas. Blue Cross Blue Shield had some premium decreases across the state in several areas across the state. So oftentimes, folks are coming in and finding plans and prices that work a lot better for them. So we're encouraging folks to come back and shop and save. You should come back to us, like I said, and update that information and compare your options for the new year. Those plans, those prices change, and you can find a plan oftentimes that better fits your needs and your budgets by coming in and updating your information and making sure you're doing that shopping on a yearly basis. Also, ACA Marketplace Insurance offers coverage that you can count on. I know now a lot of folks are hearing about things like short-term plans, association health plans, healthcare sharing ministries. Those are options that have been opened up due to some actions by the new administration. But I just want to drive home to folks that those plans are not required to cover things like pre-existing conditions. They often rather have lifetime caps again, or yearly caps on what the insurer will spend. And so these are not comprehensive plans. Those short-term plans, the association plans, healthcare sharing ministries, they are not comprehensive plans, and they don't carry all of the essential health benefits that are carried in a plan from healthcare.gov. Oftentimes things like prescription drugs aren't even available in those plans. And the last thing I want folks to remember from these 5 key facts is free local help is available. Like I said, navigators are across the state in all 100 counties. So if you have any questions about signing up, or you even want to go ahead and make an appointment and walk through the entire application process with one of our certified navigators, you can call us at 855-733-3711 or visit ncnavigator.net to book a one-on-one appointment, to have your questions answered, or to help you get through the application process and make sure that you're getting everything that you're eligible for. Next slide, please. So lastly, before I close out, I just want to give you this information one more time before we throw it over to Amanda. These are really important numbers and a website to remember. 855-733-3711 is our call center. Anyone anywhere in North Carolina can call that call center and book an appointment with an in-person assister for free in their area. Or you can visit ncnavigator.net and book an appointment right there on ncnavigator.net. You can also on ncnavigator.net check out our list of enrollment events. We have enrollment events happening across the state between now and December 15th that are walk-in friendly. So if you're not sure of your schedule or really not sure if you want to book an appointment because maybe you just have a few questions, I encourage you to find one of these enrollment events that may be in your community, and you're free to walk in those. They're on a first-come, first-served basis, and we are there to help you out to answer your questions or to help you get through the application process. So please remember these and share this information with your friends, your family, your networks. Again, we must take action by December 15th because if not, most folks will not be able to enroll after December 15th unless they have a certain life event that would make them eligible for a special enrollment period. So those sort of life events are losing employer-based coverage, aging off your parents' plan, having a baby. Those sort of things may make you eligible for a special enrollment period, but the vast majority of North Carolinians must take action by December 15th in order to get that 2019 coverage.
Thank you.
And I think that's all for me. Next slide.
Okay.
I believe that's pretty much all. Yep.
Oh, cool.
So
we'll do questions at the end.
Yeah.
Cool.
Great.
Thank you, Mark, and thank you for your work. That is incredibly helpful. Just to emphasize for people, keep that toll-free number handy, and that works anywhere in the state. And those 5 key facts that he shared are some of the talking points we want to be sharing with folks because we know that they work with consumers and helps cut through the confusion. I feel like every year there's so many policies, new policies swirling around that people are confused, even sometimes about whether the Affordable Care Act is still the law. So we want to emphasize that it is, it's here to stay, and that those 5 takeaways Mark emphasized are kind of the message we want to be spreading to folks to cut through that confusion. So again, thank you, Mark, and let's go to Amanda now. Again, she's the HIV Medication Assistance Program Coordinator for the North Carolina Division of Public Health. Thanks for being on the call with us, Amanda.
Thanks for having me, and I'm excited to be here to explain a little bit about what HMAP does for our clients that are enrolled into ACA insurance. So I just want to give a little brief overview that HMAP is the HIV Medication Assistance Program. So we have about 9,000 clients on our entire program, and so what we do is we do assist residents of North Carolina who are HIV positive and at or below 300% of the federal poverty level have access to their medication either through our uninsured program or through a sub-program that deals with insurance just like ACA insurance. So I just kind of want to talk about our ICAP program, which was the very first program that HMAP had that was related to ACA insurance. ICAP is our insurance copay assistance program. It currently has about 234 clients on the program. And to be enrolled into ICAP, again, your client just needs to be HIV positive, a resident of North Carolina, and at or below 300% of the federal poverty level. And then they just need to also provide proof that they're insured. So most of the time, we just need a current copy of their insurance card. And ICAP essentially assists the clients with their medication copay only. So once you're enrolled into the ICAP program, our client will receive a copay assistance card from our pharmacy benefits manager. and they just need to have the card when they show up at the pharmacy to pick up their medication, or if they may also have it delivered by mail. So they just need to make sure that the pharmacy is aware that they have a copay card. And so basically for ICAP, again, anybody can enroll into the ACA and then provide our insurance information for this program, and we will put them on ICAP. So ICAP's been a part of HMAP for roughly about 4 years at this point. So we were finally given permission January 1 of 2018 from the state legislature, and with the great help of NCAN pushing that we need a program like this in North Carolina. So everybody should be thanking NCAN for their hard work, for what they've done to allow HMAP to have the new sub-program that we call PCAP. So PCAP started in January 1 of this year, so we haven't even finished 1 full year yet. But so far, the program itself has exceeded, I think, all of our expectations. We originally were looking to enroll about 178 clients that we had initially identified that were on the ICAP program that were eligible for PCAP, and we are currently also at 238 individuals enrolled into the PCAP program. So just in our first 11 months, almost 12 months, we've been very successful in the PCAP program. So the difference really between ICAP and PCAP is one small thing, but that one small thing creates a lot of extra documentation. So for PCAP, we also cover the client's monthly premiums. So we also cover their medication copay and their monthly premium. This does not include copays for doctor visits or an ER visit. So just to make clear, it's medication only. So I'm going to focus a little bit more on PCAP because it has more quirks to the program and things to keep in mind when you're talking to people who are enrolling into the ACA. So some lessons learned for me for the last 11 months. If you are talking to clients who are interested enrolling into the ACA and you're able to find out that they may be HIV positive, one, see if they even know about the HMAP program overall. And if they are enrolled in our program, then it's helpful to make sure that their doctors are in network with the plan that they're going to select, more specifically HIV doctors, to make sure that their medications will be covered because HIV meds are considered a specialty med. So just to make sure that that their medication will be covered with the plan that they select, and also that their pharmacy the pharmacy that they currently use, that we may be contracted with, that they may have been comfortable with for a long time, is still also in the network of the insurer that they're looking to choose. Once your client has selected an insurance company, other qualifications for PCAP, again, they just need to be HIV positive, reside in North Carolina, be enrolled into an ACA plan, but they also have to fall between 100 and 300% of the federal poverty level. This is something that we're taking a look at internally for future steps of the program to maybe lower the FPL, but for now, as some of the guidelines from the state to maintain cost neutrality throughout the program, we have to only enroll clients that fall between the 100 to 300% federal poverty level. The other documentation we require, so unlike ICAP where we just need a copy of the insurance card, we also need a copy of the current insurance card. We need to have a copy of proof that the client applied their tax credit up front and in full at the time of enrollment. The client also has to select a medical plan only. We will not cover premium coverage for dental or vision plan. And for the most part, our clients need to select an individual plan. We can do family plans on a case-by-case basis. However, essentially what that means is that our clients and the person that they're also trying to cover on their insurance need to be enrolled into HMAP overall. So essentially that means both people on the plan need to be HIV positive. So federal guidelines will not allow me to pay for medication or insurance of a person who is HIV negative. So that's why we have the family plan as a case-by-case. But it doesn't mean we won't accept it. We just have to take a deeper look into it. And some changes for year 2. So like it was mentioned earlier, we're in open enrollment. So 2 major things are happening for PCAP for our second year. One, we opened the door for a lot of our uninsured clients to enroll. It's not that they weren't allowed last time. We just really didn't push very hard because it was new. We wanted to just keep it small just in case, of any glitches, just to work out some kinks. Now I feel comfortable that we can advertise this to our clients who are on our HMAP program, so our clients who were previously uninsured or still currently uninsured. We identified about 1,900 individuals who fall between 100 and 300% of our FPL, and we've started to reach out to those clients to let them know that if they enroll into an ACA plan this year, any plan that they want, then we can essentially cover their monthly premium and their medication copay. So that was one of the major things. And so far we've had 5 brand new uninsured people enroll into the PCAP program, so that's exciting because it's still pretty early on from what I've learned from last year to get some documentation from clients. So I'm excited about the 5 people who had been uninsured for years and years and years who finally are getting health insurance for the first time. And the other exciting thing is I actually have staff. So when I first started this program, it was me and just whoever else I could kind of pull in to help me. And now we have a functioning ICAP, PCAP team. And in fact, I have 2 of the staff members with me, Natalie Gupton, who is the new ICAP, PCAP coordinator. So if you have any further questions, you can reach out to Natalie. Her number is 919-546-1741. I'm always available still, but Natalie is now the coordinator of this program. And I also have with me Mary Harden. And Mary is also on the ICAP, PCAP team. She is our application processor, so if anybody has specific questions about how to enroll a client into HMAP overall, you can reach out to Mary, and you can find her via Natalie. And then if you have clients that just have overall questions about HMAP, PCAP, ICAP, anything, we have a hotline that clients can call, or anybody can call, honestly. It's 1-877-466-2232. That is the HMAP hotline. Just leave your name, your number, and whatever question you have, and someone will get back to you within 24 to 48 hours. That's pretty much ICAP, PCAP in a nutshell to make it not so complicated. So if anybody has any questions, feel free to ask. Thank you.
Thank you, Amanda. And we're excited that you have staff now, and that there and to hear that there are some uninsured folks already getting into PCAP. So thank you for the update.
Sure.
And on the chat line, the hotline number was posted there, so folks can see that.
Thank you.
But yeah, we just want to now open it up for questions or conversation or comments if folks want to share. I know that the famous Allison Rice may be on the call, and she does her analysis of plans for people living with HIV. She may want to give an update on where that is this year, or if there are other questions, then please feel free to ask.
Hey, it's Allison, and if this is a good time, I have a couple of things I just wanted to update folks on if this is a good time.
Yeah, perfect.
So as a lot of you know, I'm at Duke Law School, and each year we take a look, kind of a deep dive into looking at the plans and what's happening and changing with them. And I just wanted to mention a couple of things that I think are important to know. One of them is that, and many of you may already know this, is that folks in the Triangle area the range of plans has changed, particularly with respect to Duke. So folks who are Duke patients who live in the 12 counties in the Triangle, there was a plan that Blue Cross offered that was with that had Duke as the provider in it, and they've discontinued that plan. And as a result of that, 8 of those counties are no longer have a Duke option. So folks that live in Alamance, Caswell, Chatham, Franklin, Johnston, Lee, Orange, or Person don't have an ACA option that includes Duke. And so if they're going to continue with insurance, they're going to have to switch to a UNC provider, which is that UNC is now offering with. So that's an issue for their. I've been talking with the folks at Duke. There are about 186 patients that they have on their roll who were on that plan who are going to have to figure out specifically what to do. And so just a heads up for that if you're working with folks at Duke or some of the uninsured folks that are Duke patients, that make sure that they are aware of what the network situation is. Once they switch over to a plan that only allows UNC, they're not going to be able to get coverage at Duke unless they go out of network, which would be prohibitively expensive. And there's the out-of-network benefit for that UNC, the Blue Cross plan at UNC is it's like really ridiculous. So it has like a 5 times the normal deductible. So it's really not feasible. So that's one thing. Just heads up in the Triangle area. Folks need to be really paying attention to that. As you all know, folks with HIV have really close relations with their providers, and it's hard to get them to change. And so it's important for them to know what the implications would be of switching plans. There are 4 of the counties that were in that situation do have other options. In Granville and Vance, there are other Blue Cross plans that do include Duke. In Durham and Wake County, that's a new provider called Ambetter, a new insurer that does have a plan with Duke. And there are a couple things I just wanted to say about that plan from looking at it is that folks who don't have a subsidy, don't have a deep subsidy, so if they're higher income and toward the 300 or over % of poverty, it's a lot more expensive to go with the Ambetter plan than the UNC plans that are available, the Blue Cross with UNC plans. So I've already talked to one client who's going to have to switch his provider from Duke because there's just no way he can afford it. And that's particularly true in Durham because they priced them, the Ambetter has priced that the plan with Duke much higher in Durham County than in Wake County, which is the 2 counties where it's offered. Another thing about that Ambetter plan that folks need to know if they are working with clients who don't have too much income to participate in ICAP or PCAP, which is that they have that folks who rely on copay cards for their medications. Ambetter has a rule that they will, if someone uses a copay card, the value of that card that goes toward purchasing the drugs will not count toward the deductible or out-of-pocket maximum. So that's a tough situation for a lot of our clients who use those drug copay cards extensively. So they just need to be aware of that. So we are going to be releasing, putting out some information in the next couple of days that we've done every year that has a sort of a summary of some of the plan and issues, as well as some charts with what's offered where, what the drug coverage looks like, what the drug tiers are, et cetera. And so we'll get that out in the next couple of days. One thing I just say, if you haven't enrolled folks in coverage who have HIV, if they're eligible for the ICAP program or the PCAP program, their way of choosing plans might be very different because they're insulated from the cost to a large degree. So someone who's on PCAP, really they just probably want to take, it doesn't matter so much what plan they get really. It might matter to ADAP or the HMAP program because they may want to spend less on this person than they have to, but from a client's perspective, it's less about what the premium is when someone can get PCAP than what is the program that has the best, that's going to cover their doctors. I think that's all I had, and we'll get that information out soon.
Thank you, Allison. It sounds like Allison's probably open for questions as well as our speakers, but it sounds like we'll get more information in the next couple of days. So
Thanks, Adam. It looks like we have a question from the chat function from Alexandria, and I think it may be for Allison. It says, will that include the Lincoln Community Health Center?
Lincoln is on both plans. It's on the Blue Cross plan and the Better plan. So that's not a problem. It's just Duke because the UNC network is totally UNC focused, but they do include the community health centers are all in network.
Great, thank you. And we also have another question, and this may be for Amanda. It says, will the PCAP pay premiums for undocumented folks who have to buy from the marketplace at market value?
Yes. So the PCAP program, as long as you can show that your client resides in North Carolina, that's all we need. So federally, we don't even look at, like citizenship isn't a requirement for the program. It's more of just residency within the state that you live in. So for us, and we understand that if they can have this insurance and they cannot get the subsidy for right now, we don't have any restriction on that either. So they should be able to enroll into a plan, and as long as they can prove to us that they reside in North Carolina just for our program requirements, then we can take on their premium.
Great.
And I just also wanted to add to what Allison said earlier about insurance companies or types of plans. As of right now, PCAP has no restriction. So, if you have a client who's looking at a bronze plan, and that suits all of the client's needs, not just even their HIV needs, just their overall health needs, as long as they give us all the documentation that we require and they fit our eligibility requirements, we will take on those clients as well. So, they can pick whatever plan really will best suit their overall health needs.
That's great.
Thank you. And we have another question from the chat function. Is there a chance North Carolina will expand Medicaid next year?
Good question. I can certainly, I don't know if somebody else wants to take that. I know that's kind of outside of probably Mark and Amanda's parameters. I don't know if Judy has any perspective on that, but I think that certainly it's with some of the, or Allison may want to take it on too, but I think after this past election, certainly a lot of new states are going to be having Medicaid expansion. I think it's still, maybe a bit of a tall order in North Carolina. There's probably still obviously a good amount of reluctance in the legislature, but the governor is quite supportive, and perhaps with the change from no longer having sort of a veto-proof majority for conservative sort of opponents of Medicaid expansion, it could open up new possibilities for the governor to push that, and it's certainly he's indicated multiple times and in multiple ways that it's one of his top priorities. So it's certainly, I think, something that folks should keep on their radar, and will certainly be a major part of the public debate moving forward, especially as sort of more states, both sort of Republican-dominated and Democratic-dominated, expand Medicaid, and as health care really becomes more of and the Affordable Care Act becomes more of a helpful issue in campaigns as opposed to hurting candidates who campaign on health care affordability and access. That's just my take from working on it. I haven't worked on it in a little while recently, but certainly before I came to the trust, I worked a lot on the issue. Does anybody else have something to say about that? All right.
No, I don't know if Allison had any comments on that.
Yeah, do you want to say anything, Allison?
I have nothing more to add other than that it has been pointed out to me by some lobbyists who are well connected that the advantage this session will be that Cooper has the threat of vetoing things, including the budget, that give him a lot more leverage in terms of pushing for Medicaid expansion. The other thing I think that's important around that is that if that conversation does really happen in earnest, that it's likely that it would include work requirements, which we've been seeing nationally, and was in even the governor and the secretary in North Carolina endorsed that idea as a way to push it through. And I think that that's something people have to look at really closely because of how that impacts people's ability to maintain insurance, as we've seen in Arkansas, where work requirements have thrown a lot of people off of coverage. So just a heads up for that.
Great points.
Great, thank you. And just as a reminder, all of these slides, as well as the contact information for our presenters, will be shared. And this webinar was recorded. So we still have time for maybe one or two more questions. And at this point, if you'd like to just chime in, please do so.
Yes, feel free to speak up if you have questions or comments. I know we'll be pushing out this recording. It'll be on social media and other venues, so please look for it if you need to share this information with others as well.
This is Allison. I'll make one more comment about plan selection for people that are on ICAP or PCAP, and that there's kind of like perversely, it's sort of the opposite of what one would expect. One might try to find the lowest drug cost sharing because that's the important thing for folks. But since the HMAP program is paying that, and that's how people will accrue a lot of cost to get through the deductible and out-of-pocket maximum, it actually makes sense to choose a plan with the most expensive drug coverage, because people with HIV are going to use such high drug like that they'll get to the out-of-pocket maximum within a few months with a high drug cost sharing. And so like picking a plan like some of the Cigna plans that have actually low cost sharing for HIV drugs, it actually doesn't make sense if you're going to get the HMAP assistance through ICAP or PCAP. It does make sense if someone is paying their own and they're over the ADAP HMAP income limit. But for folks who are in that sweet spot, choosing plans with high drug coverage and lower out-of-pocket maximums, that's the sweet spot.
Thank you. Any other questions or comments? All right, if not, I think we can wrap it up. Do you have any closing comments, Judy?
Well, it looks like we have one more question.
Oh, good. Okay, good. We have time.
The chat function. It says, what keywords can a patient use to ensure they get the plan to help with their meds without disclosing their status?
Do you have thoughts on that, Allison, or others?
Yeah, Allison might be the best to answer that, but I can tell you that our in-person assisters are really well-versed at sitting down with folks and kind of understanding what their needs are, and being able to, help them compare plans and prices and what's in their formularies and what is covered, or providers are covered in network and all of those sorts of things. And being very discreet and confidential, of course, about everything. Confidentiality is one of the most, if not the most important thing that we do each and every day. So we are able to really help folks to understand their options and what's available to them. So I can say that for our navigators.
One thing I would just say is that we all, as those of us who work in the HIV world, know that that is something that HIV status is something that many people are very careful about disclosing in their local communities. And I mean, I've had clients who went to another state to apply for Social Security because they didn't want to go into the Social Security office in their county and disclose their HIV. Even at that level of like official government, there's concerns about somebody they know is going to be involved with it. In the past, a lot of so somebody who, the other resources, a number of the clinics do have folks doing enrollment assistance. I don't know if that has gone down. Maybe Amanda might be able to speak to that. But that there are options to get assistance within the HIV world. And the one other thing, too, I think that we didn't mention that's important to remember is that folks who don't get insurance can still get Ryan White coverage to allow for their doctor visits and to pay for their drugs. And so that if people don't feel like they can find a plan that works for them or have their doctor be in network for the plans available to them, that the status quo of Ryan White is still available as long as that there's been an effort to try to pursue options or to at least check out options.
Thank you. Those are helpful additions. Let us know if people are chatting still, Judy.
Yes, but I think Allison answered the question. So I'll just share the question. It says undocumented consumers and those with DACA cannot enroll in ACA plans. Is there any assistance available to these undocumented uninsured consumers? And then it's Ryan White. But I don't know if there's any other. I know folks can buy being undocumented, and if you have DACA, you're eligible through your employer to receive health insurance, just not through the Affordable Care Act. As well.
That's correct. That's correct. And also, folks that aren't documented and are not able to take advantage of marketplace coverage, we are, like I said, we work with each community to find referral networks and different resources that we can refer those folks to. So if there are folks that are undocumented and may not be eligible for marketplace coverage, we're still happy to help them make connections to other resources in their communities.
Great, thank you. And also, as a reminder, right, Ryan White helps pay for very specific treatment and medications, but if folks have other needs, other health needs, Ryan White funds won't cover some of those, and so going through some of these referrals may be a good option, so thank you for that. And so I think that we are right at almost 1 o'clock, and so we want to thank everyone for being with us today. And as we've mentioned a few times, we will be sharing the slides and the contact information for everyone. And if you have any additional questions, please feel free to forward those to myself, to Adam, to Mark. I'll also include Allison's contact information as well as Amanda and Lee's, if you have any additional questions as we approach the end of open enrollment in December. And I'll turn it over to Adam for any final remarks.
Thank you, and thank you again, Judy, and the Latino Commission on AIDS for handling all the technology today and getting all the questions consolidated. And I'll thank also Lee and the North Carolina AIDS Action Network staff that does amazing work, and I'm just on the board, so I have the easy part. but they really do all the legwork, and it's really a lot of what they're able to accomplish is through partnerships with folks like the Navigator Consortium, like the Latino Commission on AIDS, and like the DHHS and the Division of Public Health. So thank you to all of our partners, and thank you to all of you on the call today. You guys are spreading important information, and we really have to have a strong word of mouth campaign because, again, sometimes the advertising is not there. It's not reaching the populations we most want to reach. So feel free to listen to this recording, share this later with your networks, and like Judy said, she'll share our contact information for any follow-up questions. So I hope everybody has a good holiday week, and thank you again for being on the call.